and speak about this about the liver. And the title is quite challenging because liver matters, so does kidney in type 2 diabetes. And I'd like to thank the organizer to invite me today, have invited me today. So just a second, I need to go. Okay, these are my disclosure. So we all know that diabetes is highly prevalent, especially in Southeast Asia, and it's the prevalence it's increasing, and is supposed to go up very much also in the next years. So there are several complications related to diabetes, and but the liver is usually not considered among the diabetic complication. And we and others have worked a lot in the field of non-alcoholic fatty liver disease. That is actually a metabolic disease that is highly related to diabetes and all the metabolic complications related to diabetes itself. So I just put here a recent commentary by Ken Cusi that was titled "Time to include a non-alcoholic steatohepatitis in the management of patients with type 2 diabetes." And this is because type 2 non-alcoholic fatty liver disease and non-alcoholic steatohepatitis are recognized as major diseases, but are not considered among the comorbidities of diabetes complication, at least, or marginally, at least in the 88 guidelines. So I think there is a central role of the liver. The liver is the organ that first metabolizes all the nutrients. It's also transforming lipids like free fatty acids coming from both of the adipose tissue, all from the diet, in triglycerides and then secreted as VLDL. So it's very important for lipoprotein metabolism and lipid management as a whole. It's also secreting some hepatokines, among the most important C-reactive protein, fibrinogen, PI1, phytoin A, FGF21, and also it's very important because it's the organ that is producing glucose. So it's the organ that is responsible for the glucose production and for fasting hepatic hyperglycemia. Also, because of is managing all the secreting the most important lipoprotein, is highly related to atherosclerosis and coronary artery disease. So NAFLD is the major liver disease. It's more prevalent than other liver diseases like hepatitis, for example. We now have some cure for hepatitis C, but and also it's a metabolic disease characterized by the accumulation of lipid droplets in the liver, and is considered this ectopic fat. And the NAFLD cover a large spectrum of liver damage because it's going from simple steatosis to non-alcoholic steatohepatitis to cirrhosis and hepatocellular carcinoma. The global prevalence of NAFLD is now considered to be 25% in the general population. And you see here an article that was published now a few years ago, where it's showing that the prevalence is much higher in the Middle East and Southern America, but is quite high in both Northern America, Europe, and also Asia. But the prevalence of NASH, it's usually low, 2 to 5% in the general population, but this going much, it's increasing to 15 to 55% in obesity, and in type 2 diabetes, it could range from 20 to 80%. I say it could range because to have a diagnosis of NASH, we need a liver biopsy. So there are not many data available about the real prevalence of non-alcoholic steatohepatitis in the world right now. So it's important because NAFLD is not only progressing to liver disease like cirrhosis, but is also highly associated to cardiovascular diseases. And actually the mortality in these patients is mainly due to cardiovascular disease than to liver disease and the cirrhosis itself. NAFLD is also present in lean individuals. This is an important message because it's not only associated with obesity. Obesity is, of course, a major risk factor for fat accumulation in the liver, but the things that this can happen in lean individuals, it's an important message that should be taken in mind. Also because in this multivariate analysis that was published almost 10 years ago now, it shows that lean NAFLD is independently associated with younger age, male sex, and decreased likelihood of having increase insulin resistance, you see 4.23%, and hypercholesterolemia, and also hypertension. I pull out this article that was published last year about the prevalence of non-alcoholic disease in India. And this was done, this study, in healthy male blood donors. You can see here that among these subjects, more than half had NAFLD, and this was diagnosed by ultrasound. And this was especially, you see here the characteristics of these subjects. They tended to have a higher waist, hypertension, diabetes, increased triglycerides, and decreased HDL. And indeed, most of them, the great majority, more than 8%, had at least one or two or three factors of the metabolic syndrome. The prevalence of NAFLD-NASH in an hospital settings is much higher than in the general population. But you can see here that is mainly the obesity and the type 2 diabetes that is driving the prevalence of NAFLD and NASH. So how do we diagnose NASH? I put here the diagram that was suggested by the guidelines of European Society for the Study of Liver Disease and of diabetes and obesity. And you see here that first you need to have a confirmation of presence of fat in the liver. This can be done by ultrasound or by MRI or by steatosis biomarkers. There are several scores. And if steatosis is present, that it is important to see if enzymes are normal or abnormal. And of course, if there are all normal liver enzymes, it's important to refer to a specialist to see if it is possible or it is appropriate to have a liver biopsy. Of course, there are several imaging techniques. The most reliable is magnetic resonance imaging because it gives you a very nice picture of the liver. There are now also way to identify liver fibrosis, presence of liver fibrosis by magnetic resonance imaging, uses elastography, for example, but also ultrasound can be used. But ultrasound is detecting presence of liver when the liver fat is above 15 to 20%, usually like even 30%, while the cutoff by MRI is 5%. So one is 3 times above the thresholds. This is instead the non-invasive assessment of risk stratification of patients with suspected NAFLD. So when you identify patients with NAFLD, you need to find out if they have fibrosis, because fibrosis is the main risk factor for mortality and for progression of NAFLD. And there are some scores like the FIB-4 of the NFS that can help you, and these are based on platelets, triglycerides, liver enzymes. And so it's quite easy, at least, to have an idea about the severity of NAFLD. And also, as a second line, if you find an intermediate or a high risk, it is important to rule out the presence of fibrosis using, for example, the FibroScan and or imaging before having the patient referred to the hepatologist and to leave the liver biopsy only in those that have an intermediate to high risk. The predictors of fatty liver, as we say, that there are several. Of course, there are BMI, insulin, so insulin resistance, increase waist circumference, alcohol intake. It's a major risk factor for fat accumulation in the liver, hypertension, decrease in physical activity, so sedentarity, but also Western diet with fructose, having a visceral fat accumulation, type 2 diabetes, age and menopause, but also there are some genes that are predisposing the subjects to have a hepatic fat accumulation. And the most important are PNPLA3 and TM6SF2 that have been associated with higher liver fat content and increased risk of steatohepatitis. So it's you can see from this slide that the presence, having the genotype MM of the PNPLA3, it's actually increasing the risk to progress from steatosis to NASH and cirrhosis, and also to hepatocellular carcinoma. This risk is much higher as the BMI is increasing. So BMI together with the presence of the mutation in the PNPLA3 is increasing of several folds the risk to progress from simple steatosis to NASH and cirrhosis. PNPLA3 is also important. You see from this nice cartoon what is the prevalence of PNPLA3 in different countries in the world. In India, actually, the PNPLA3 mutation is not so high compared to other countries, for example, Mexico or the Hispanic American in the US, where almost half of the population have this mutation. And this is also another study that I found that is showing the genetic susceptibility for NAFLD in Indian ethnicity. You can see that from this nice study where they studied ancestral South Indians and the Northeast Indians, that TM6SF2 gene was significantly associated with a 2.7-fold of higher risk of fat infiltration in the South Indians, and instead was PNPLA3 that was significantly associated with the risk of fat infiltration in the Northeast Indians. So taken together from this third part, of course, hepatic fat and increased waist, that is an index of visceral fat, are associated because we know also from the criteria of metabolic syndrome, we had triglyceride, reduced total cholesterol, diabetes, increased liver enzymes, hypertension, and this, of course, it's make the subject a high risk for both type 2 diabetes and cardiovascular disease. So the liver, it's very important to define the risk of both diabetes and cardiovascular disease. Moreover, these NAFLD patients, as I told you before, they have a higher risk of cardiovascular disease compared to the general population. And this is, of course, it's much higher is they also are diabetics. So NAFLD plus diabetes is further increasing the risk of coronary artery disease and in general cardiovascular disease. And so this is a cartoon to show the mechanism. And this is also because, as I said, these subjects, they have an increased release of glucose and lipids, CRP, fibrinogen. So they are platelets, they have a higher platelets, so they have an atherothrombotic profile, hyperglycemia, hyperlipidemia, and we know these are major risk factors for cardiovascular diseases. And of course, as the fat is accumulating in the liver, it's also accumulating in other organs. So we can find fat in the pancreas, but also fat in the heart. So not only as epicardial adipose tissue, but also as intramyocardial fat. And this is making the heart at high risk because it's decreasing fatty oxidation, is impairing mitochondrial function, is increasing atherosclerosis of the coronary artery, and is impairing endothelial function. So at the end, is decreased cardiac function. So this is also other not only the coronary artery disease, there are also aortic valve sclerosis and atrial fibrillation that are associated to NAFLD related cardiac complications. We have found that those with fatty liver, they are at a higher risk to develop coronary artery disease, even if they are healthy, young, and without diabetes and hypertension. You see this, it's in all studies, but also because this fatty liver index is associated, was the best predictor of the presence of early carotid plaque. And these all subjects, they had a intima media thickness that was below the, was within the normal ranges. Despite that, those with the fatty liver, they had early carotid plaques. And also, this has been shown, you see here that carotid IMT is much thicker in those with NASH compared to those with simple steatosis. And this is also one of the and also this in this nice review, Targer has shown that some of the mechanisms that can explain the atherosclerosis and cardiovascular disease are due to the fact that subjects with NAFLD and NASH, they have, chronic inflammation, hypercoagulation, hyperfibrinolysis, atherogenic dyslipidemia, and also the dysglycemia. There are also some of these genes, the PNPLA3, TMSSF2, they are also related to coronary artery diseases. So subjects with, because they are, these genes are involved with the lipoprotein metabolism and secretion of VLDL and LDL. You see that those with increased triglycerols were those that they have the mutation, this is of glucokinase. So this is the odds ratio. Subject with the TM6SF2, actually, they are protected from coronary artery disease because this gene is involved in the secretion of VLDL. So when the gene, you have a mutation, the secretion is impaired, so the triglycerides, they stay in the liver. This subject, they develop NAFLD, NASH, and cirrhosis, but they do not have atherosclerosis or hyperlipidemia, just because there is an impairment on lipid secretion. And the same is for the PNPLA3, while instead the glucokinase that is acting on the glucose is actually associated with a higher TG, plasma TG, LDL, and cholesterol, and also type 2 diabetes. So among the prevalence of comorbidities, as I said, there are metabolic syndrome and type 2 diabetes, but also, as we know, these subjects, they have hypertriglyceridemia, hypertension, but also they have a chronic kidney disease. And the prevalence of these comorbidities are much higher in those that have steatohepatitis compared to those that have simple NAFLD. So the initial attention on the relationship between chronic kidney disease and NAFLD went back to this first meta-analysis from Musso that showed that those with NAFLD, they had an increased risk, an odds ratio of 2.1 compared to those without NAFLD of having chronic kidney disease. And then other studies have been published. This is a recent, just published review on this issue, and is NAFLD as a driver of chronic kidney disease, because presence of NAFLD identifies a group of individuals who are at increased risk of chronic kidney disease, and this association is increasing with severity of NAFLD. And also the severity is the association between presence and severity of NAFLD and increased prevalence of the incidence of chronic kidney disease, independently of obesity, hypertension, type 2 diabetes, and other common cardiorenal risk factors. So there are several factors that are common in subjects that have NAFLD and chronic kidney disease. Visceral obesity is one of the risk factors for both diseases: arterial hypertension, atherogenic dyslipidemia, type 2 diabetes, metabolic syndrome, hepatic systemic insulin resistance, inflammatory state, prothrombotic state, increased uric acid levels, and also there are others. So it is becoming important that this subject with NAFLD should be checked for chronic kidney disease, and at the same time, subject with patient with type 2 diabetes and or chronic kidney disease should be checked and for a presence of NAFLD as one of the comorbidities. And these are the potential mechanisms that are linking NAFLD and chronic kidney disease. As in many metabolic disease, the unhealthy, calorie-dense, and poor in fiber diet, it's a major risk factor. Not only because it's promoting an imbalance in the gut microbiota and the dysbiosis, but also because, and so that's increasing the inflammation and alter the levels of short-chain fatty acids, but also because there are it's increasing the abdominal fat accumulation. We know that there is a strong relationship between the visceral fat and liver fat. The increase in fat in general, it's increasing the insulin resistance and the flux overflow of free fatty acid to the liver and the other organs, and promoting lipotoxicity not only in the liver, but probably also in the kidney. There are some coronary cardiovascular disease risk factors that are also nephrotoxin, like fibrinogen, C-reactive protein, and we have to keep in mind that these TMAO that have been shown to be associated with atherosclerosis, but also with chronic kidney disease. And of course, there are processes associated with aging, because age is a major risk factor for all these diseases. So just to conclude, I think we have a metabolic NAFLD that I call type 2 NAFLD, because it's associated with increased hepatic triglyceride synthesis, and of course not only due to the diet but also from de novo lipogenesis. That have a high risk of coronary hepatocellular carcinoma, type 2 diabetes, cardiovascular disease, and abnormal lipid storage. And this, of course, it's associated with a positive energy balance. It can be present also in subjects that are lean, because there are not an adipose tissue expansion, and so most of the extra fat is going to tissues like the liver. It's important to check for the genetic NAFLD, so presence of genes that are favoring the hepatic fat accumulation, but it's also very important to follow the other organs as comorbidities. And among these organs, I think it's becoming clear now that the kidney can be becoming, there could be like a chronic kidney disease more prevalent in a subject with NAFLD. So to look for glomerular filtration rate is very important in these subjects. I'd like to complete this presentation, to conclude with the thanks to my group. in particular Melania Gaggini, Fabrizia Carli, Demetrio Ciociaro, Chiara Barbieri, Sara Guerra, Barbara Patricio, Samantha, and Marco. I think they are following this presentation today. Of course, a big thank you to the group in San Antonio, where I'm an adjunct professor, and Ralph De Fronzo in particular. Most of the study on NAFLD have been done in collaboration with the University of Torino, Elisabetta Bugianesi, and your Catholic University with Geltrude Mingrone. And we have now, of course, you know, a long collaboration with Ken Cusi since when he was a UT Health Fund, and of course the grants that support my research. Thank you very much for your attention.